Welcome to today's podcast brought to you by Eno Health Magazine. I am Dr. Vishnoi Pradan, your host for this enlightening conversation with our esteemed uh, guest today, Dr. Kamini Khillan. Dr. Khillan brings a wealth of expertise as a blood transfusion specialist at Sir Ganga Ram Hospital, where she has also served as a distinguished quality manager. With a rich tapestry of accomplishment to her name, Dr. Khillan embodies excellence in medical field. Join us as we explore her remarkable journey and the significant contribution she has made to the healthcare industry. Welcome to our podcast, ma'am. Uh, as you have been in the transfusion industry for the past few years, to begin with, I just want to ask that what would be your one piece of advice for any person who is going for a blood transfusion for the first time?
First of all, thank you very much for inviting me to this podcast. I'm honored, and this has been an opportunity to bring forth some of my experiences which I had in this field. So, with which I have been like associated for almost 20 years now.
Okay.
So, uh, so you started with an advice right from the beginning. Okay.
Yes.
So somebody who is coming for a transfusion as a patient should
Yeah.
actually get oneself evaluated. That's one properly. Usually, internationally, it is considered that one should first try and correct the anemia
Mm.
before you actually jump into a transfusion. But normally, with private practices and the way it is done, the transfusion itself, I mean, the time period between the surgeries and between the transfusions is less. We don't have that much time. But
Mm.
ideally, one should try and reduce the number of transfusions a person is trying to have throughout the surgery or the procedure. That's the ideal one.
Okay, so now we have also started to look at everything from a global perspective. So what are the recent practices that we have been seeing in the transfusion industry globally?
So, if I just go through a little bit of evolution of this transfusion medicine field, then I would say that it is something which was there in the form of whole blood, say around 1960s or 70s,
Yes.
and with the professional donors or donor paid donors. But then with 1980s coming up of HIV, there was a boom in what you call as the safety of blood. And this safety of blood over a period of like say 50 years now almost, and especially in India over a period of 30 years, I would say has really seen an exponential and phenomenal growth.
Okay.
So the something which started with selection of donor being safe is still continuing, but modalities overall in the world are now focused on how safe you can make the blood by testing. That is one. And
Mm.
then by clinical algorithms by which you can decide how safe it is to give it to the patient. Those are the
Okay.
perspectives being developed nowadays. And of course, the quality aspect of it, the monitoring, the
Mm.
hemovigilance, how safely you are transfusing, and then you are following up with the patient to see how safe the patient is after the transfusion. So it completes the whole spectrum. And so this is how the blood banking is evolving, or it has evolved over the years. Globally, again, I would say, if you're asking specifically in the global terms, the focus is on the personalization of transfusions. In the sense, you are trying to do a genotyping of the donors, and then you're
Mm.
trying to match at that level that whether the transfusions are matching with the patient or not. Of course, this is more relevant for patients who are having thalassemia or chronic transfusions requirements.
Yeah. Now when we are talking about like specification, that brings out there would be challenges associated with it, right? So what according to you are the challenges that we are seeing these days in this particular industry because of all the specifications or testing?
First of all, are the resources. Of
Mm.
course, monetary aspect of the resources because most of the tests are expensive. So there are
Mm.
certain minimum requirements. Blood is considered as a drug. So there are certain minimum requirements which every blood bank has to furnish. At least in India, we are talking. And for that, we have 5 mandatory tests on the blood. So HIV, HBsAg, HCV, then malaria and syphilis. So resources for these tests provided by to government setups are up to ELISA level. But if we
Okay.
go to the higher safety level, then there is chemiluminescence, the clear. Then you have
Hmm.
one more step ahead, and that's called NAT testing, the nucleic acid testing. So the availability of those resources, further on the cost involved. So the
Hmm.
blood, it affects the overall availability of the safer blood to the patients. That is one. The second and most important challenge that one has is the change in the mindset of the
Okay.
people. So even after 30 years, 40 years of counseling, you can say, or raising the awareness, we do get such aware people in metro cities. But if we go a little bit to the periphery, to the villages, people are less prone to donate blood
Hmm.
as voluntary donors. The total percentage, I won't say the term numbers, but of course, the percentage is much, much less. And there are very few states which are actually into majorly voluntary donation. But most of the times, most of the blood banks, most of the places, it is a replacement donation. So the
Okay.
main focus has to be on how we can change that mindset. That's the main challenge. That patient relatives don't have to come.
Hmm.
We have enough inventory to give them, and that comes from voluntary donation. So that has to come into the public or the society.
So, recently we have been seeing a lot of initiative from the governments and also. So now we have e-RaktKosh
Mm.
program going on. So how do you think it has helped us? Like, has there been some significant impact or not?
So yes, so I was also one of the advisor level at that person at that program, at least training part, not the development of the this thing, but the software, but the training of the medical officers for that
Hmm.
particular software. The purpose of this software is in a way to channelize, to centralize, to combine almost all blood banks which are there. We have almost 3,200 blood banks in India. The
Hmm.
level of every blood bank is different. We have blood bank from associated with a hospital. We have a blood bank associated with an NGO. There are certain private blood banks. So
Yes.
it's this process has sort of tried to bring a transparency in the system. Everybody is supposed to put in their slot positions apart from keeping whatever they require, rest is to be put. So it's available. The donors, they can register themselves, availability of the donor to the donor that, okay, this area is having less donation. If he wants to go and donate in that area, that is also there. So
Hmm.
overall resources. So there are many things to that. There is a whole gamut of things which is there in that e-RaktKosh. So
Hmm.
overall, and the government also can keep a surveillance over the whole process that it is going on. That okay, this particular area is requiring more attention, considering the training part or things like that. So this is how the e-RaktKosh has a very relevant role to play, with every blood bank required to register there and put in the required amount of information that is.
So, do you think like through some advancement or something we can enable counseling also as a branch of this program itself? Do you think that it is possible?
It, as a branch to this program for e-RaktKosh, I won't say, but yes, this is something which can be worked through ASHA workers. That's
Okay.
what I think. At the rural level, we have those healthcare workers, ASHA supportive workers who go to everybody. They are in contact with not only the family, especially the pregnant females. So at that time, the whole family is very receptive.
Hmm.
And then PPH is one thing which can cause untimely death of females in the village or rural area till the patient is brought because the patient bleeds very badly in PPH. So those are
Hmm.
some things where the or through Sarpanch, through the rural setup, the hierarchies. So at those levels, the awareness should be there. It's just cannot be at who are educated, they are educated. But
Okay.
those who really need is the general public who really wants to get should be made aware of that what is the importance of this one intervention. So it should go at the grassroots level.
So I mean, now that we have spoke about counseling and everything, what is that one misconception that you are seeing in everybody's mind when it comes to giving blood or getting blood for that matter?
Giving blood, the most important misconception is that I will go weak.
Hmm.
My blood if my hemoglobin is going to decrease, and if I give blood, then there will be weakness. This is general misconception, or I can get infections after giving blood. So I would like to just clarify that government has mandated a minimum hemoglobin requirement of 12.5 gram per cell for a donor. So
Yes.
if the donor has a hemoglobin of less than that, the person himself or herself becomes ineligible for donation. And beyond that, if we take, then usually the recovery is there within 3 months. Whatever is lost is recovered maximum within 3 months. That's why we
Mhm.
allow a donor to donate after 3 months, as far as the red cells are concerned. And as far as getting infection part is there, then the bags which are used for this thing, unless and until they are reused as part of some wrongdoing from the blood bank side or from the organizer side or anything, which is normally should not be there. Bags, they come with a needle which is capped, which is
Yes.
totally sealed. So the seal, you make sure that the seal is open in front of you,
Yes.
and then you can get this.
Mhm.
So area where the prick is being done is cleaned. These are the two main areas, ways by which you can get infection. Either it is a reusage of bag, or it can be the area of prick. So if that is taken care of, then there is no chance of a donor to get an infection by
Mhm.
donating.
So what are the other criterias on which we reject a donor? Like if somebody has come to us, our camp, suppose, and what would be the other criterias on which basis you will say, ki, nahi, we cannot accept your blood?
If I want to go through the list by drug controller requirement, there are at least a 3-page long list.
Okay.
The whole thing is not possible, but
Hmm.
yes, there are certain minimum a person should have an age group of between 18 years to 60 years.
Hmm.
The person should have a weight of above 45 for a whole blood donation, that is 350 ml, and 55 and above for a 450 ml donation. Usually, not more than 10% of the body volume of the blood is that is collected in a bag. And that's the
Hmm.
allowed one. Apart from this, should have eaten properly, should have slept properly. These are simple things, but they can affect any
Okay.
medication they're taking, blood pressure medication, diabetes. To be very honest, these are not deferral criteria.
Okay.
If a person is having a hypertension but is controlled with the medication, he can do it. If it is diabetic, if he is not on insulin, taking oral diabetics, no complications, normal sugar being maintained, can donate. So these are some misconceptions which people are having with regard to the routine. Apart from this, of course, any infection a person is having, even this thing, tooth extraction, and then there is anti-rabies vaccination, tattoos. These are some of the common things which make a person defer for
Hmm.
some specific time period. Those
Okay.
time periods are defined in the SOPs of the drug controller. So these are some of the things which we take care of.
So you have also like worked as quality manager, as I have read. So how do you think that NABH and all these accreditations has brought more regulation to blood transfusion? Like what are the parameters that has helped?
So first of all, I'll tell you that NABH is not mandatory.
Okay.
Drug controller's license is mandatory for working of any blood bank.
Hmm.
So if we want to go for an NABH certification, or any blood bank goes for an NABH certification, it is when they have an inclination to improve their quality, when they
Okay.
want to. So in that, you have, like any accreditation, criteria are there.
Hmm.
For that purpose, you need to maintain certain documentations, particularly importance of cold chain, particularly the importance of the QCs, which you do for the testing purposes with your machines or with this, how you handle your reagents, how you store your reagents. Even it also includes how you keep your records properly or not. So there are, and then you are supposed to have a quality or QC requirements of your components which are prepared. So
Okay.
whether 1% of your say platelets or your red cells which you are preparing every day or every month, that
Hmm.
much has to go into testing to look for benchmarks which are already set and they are prepared in annexures that okay, this much has to be there. So NABH helps us to go deeper into the quality. It becomes a
Okay.
quality management system basically, where
Mhm.
you look into the whole aspects of the quality, right from the preparation to actual monitoring of your quality. So that's how it helps.
So these would be the key components based on which that we'll get the NABH accreditation, and this will be a add up. I mean, it is not a mandatory thing
No,
to
it's
have.
not mandatory. You can do all of this without NABH also, if you are
Okay.
inclined to that. But yes, a
Okay.
certification helps because then
Okay.
you are regular with your maintenance of records.
Hmm.
And they
And
do, yeah,
yeah, you can complete
and
that.
it's okay. Yeah,
And then, can you like provide me a overview about ABO incompatibility? We have been, it is strongly associated with blood transfusion. So what is the overview of it?
yeah. If I talk about adverse reactions with respect to the blood transfusion, then there are reactions which are taking place because of blood which is not leukoreduced, which is the most common.
Hmm.
It's called febrile non-hemolytic transfusion reaction. Usually the blood transfusion is there and there is a fever. So
Okay.
that has been taken care of by leukoreduction of blood. You prepare blood in such a manner that the filters are attached to the bag and you remove the WBC at the time
Hmm.
of preparation itself. That's the highest technique that is available right now.
Okay.
Then there is adverse reactions can happen in the form of allergic reactions. Those
Hmm.
allergic reactions are mainly due to platelets and due to the FFPs. These are the plasma content, protein contents. Usually, it is not possible to do away with this because plasma content or plasma antigen or antibodies, it's not possible.
Hmm.
The third important thing is your hemolytic transfusion reaction, which you are trying to ask me, and that is ABO incompatibility.
Hmm.
Just remember that ABO incompatibility type of reactions, 99% are clerical errors.
Okay.
Whether the sampling which has been done from the patient side is wrong, or the blood bank which has mixed up the two samples because the
Hmm.
patient's name was same or the registration number was not taken care of. So
Hmm.
99% of the cases, the hemolytic transfusion reactions are clerical. But in general, if you talk about the incompatibility, then I would say in terms of that the person who is A group can be transfused with A as well as O. But we are
Yes.
talking usually in terms of packed cells because they
Hmm.
have very little plasma. Nowadays, the concept of packed cells is there. Whole blood is there at periphery, many of the centers, many places. Even in Delhi,
Hmm.
you have whole blood at many places. But when we talk of these cases, then A can be given A and O,
Hmm.
B can be given B and O group can be given only O group, and
Yes.
AB becomes a universal recipient.
Hmm.
It can take A, it can take B, it can take AB, it can also take O. So overall, O becomes universal donor and AB becomes universal recipient.
Hmm.
But a little bit of twist, we have RH factor also.
Yes.
So we can have A positive, A negative, B positive, B negative. Similarly, AB positive, AB negative, O positive, O negative. So if all the eight are considered, then O negative is the universal donor because it has no antigen.
Hmm.
And AB positive becomes the universal recipient.
Hmm.
So this is how the thing goes. But if we talk in reverse, when we talk of plasma, then AB plasma has no antibody because you do not
Okay.
produce naturally occurring antibodies to yourself routinely. So if a person is AB positive, the person has no anti-A and no anti-B in their plasma. So that plasma is like a neutral plasma. So that can be easily transfused in case of if it is suppose a person is not able to get a same group platelet or same group FFPs, that AB plasma or AB platelets can be easily transfused.
Okay.
So this is how the whole blood banking basics of blood banking they work like this.
Okay. So, as you said that it is mostly because of some clerical error or patient identification error. So, do you see any innovative thing that we could have which could reduce this, which we
This is
do not have right now?
no we there are certain facilities available, but
Hmm.
of course they come with a cost. So you have
Yes.
RFID systems available
Hmm.
where you tag the samples. There is dual sampling system. You send first sample to the blood bank, does the sample, then there is a By the time of request generation, there is a second sample coming.
Okay.
Similarly, while you are issuing the blood, there is an RFID system which has got a chip which is pasted on the blood bag. And there are specialized refrigerators in which you are storing, and there is a software which reads those chips. And it
Okay.
actually shows you in the system that at which blood group or which particular bag is placed at which set place in the whole fridge. So that helps. Then there is a third level where similarly there is a box which opens only with the specific code which comes with that RFID. So once you have put the bag in that box and it goes to the patient, so there is a code which is specific to the patient. It opens only with that code. So this
Okay.
is how we are creating various levels of safety as far as
Okay.
this thing is concerned.
So I
Not
think in our podcast we have covered the basics of blood transfusion, or who are the universal recipients and the universal donors. Then we have got some idea that how NABH works around things, how we could innovate things and have more patient centric approach or more patient safety. So like summing up today's podcast, what would be like one of your advice to the young generation we have, uh, who is more keen towards health? So what would be your piece of advice for them?
health or help. Anyways, before I go to that part, I would definitely tell you something which is called SDP. Since
Okay.
this is something which people should know,
Okay.
because this is something which is being used during dengue a lot.
Okay. Okay.
So when we collect whole blood, whether it is 350, particularly 450, we are making a platelet which is called single donor platelet. Oh, sorry, which is called
Yes.
random donor platelet.
Hmm.
It's just a 90 ml product.
Okay.
And we have to give almost 4 to 6 platelets to one patient to correct the platelet count or the dose effect that we need to give to that patient.
Hmm.
But there is a product which is called SDP, or single donor product. In layman's language, people call it jumbo platelet.
Okay.
So the difference is that this is something which is made with the help of a machine. It's a specific apheresis machine. There is a kit. It's totally safe. A person can donate after 3 days
Okay.
a platelet. So within 72 hours, there is a recovery of whatever the platelets has been removed from your body as a product. And the
Okay.
product which is prepared is safer than, you can say, RDPs, because it has got low leukocyte count, and it also has a product count more than what you get from a 5 or 6 of platelets joined together. So you get a dose which is we can set with the help of the machine. And SDPs, they are much more useful products. So people should come forward to donate SDPs and should not get afraid of that. Particularly, they're very helpful in dengue and then chemotherapeutics and patients who are regularly on low platelet counts for some reason, usually cancer patients. So those SDPs are there because it is very difficult to find donors for SDPs.
Okay.
People come, they say, okay, I'll donate blood. And then if you ask them for SDP, they will not register, or they will not say, okay, I don't want to be, because it's almost a 1 hour procedure. So it's not about
Okay.
time also, it's all about a mindset. Those are totally safer than the blood loss is very less, not more than 50 to 70 ml in this. Only platelets are removed. So this product should be taken care of.
Okay.
And,
So I think by this podcast we will have more people getting aware about it and coming forward and doing the needful for the particular thing. So is there anything else, ma'am, you want to add,
I just
which?
want to say that blood banking is a very upcoming field. It has grown a lot in safety as well as, but the main, you can say, baseline is donor.
Okay.
So donors, and in fact, the safety of the blood starts with the donor. So
Okay.
honesty, telling about your proper history, coming
Hmm.
forward to regularly donate, because regular voluntary donor is considered to be the safest,
Hmm.
and participating in this voluntary blood donation programs as much as possible.
Hmm.
Not only for the certificates, not only when your somebody is requiring and you're going, but
Hmm.
as making it sort of a habit to, you can say, associate it with a uh, function in the family. It can be either
Hmm.
your birthday, your spouse birthday, your friend's birthday. It can be some festival. which you can associate with it, and you also get reminded every time, okay, this is the time then I'm donating.
Hmm. Hmm.
So this is how it, brings in that feeling, okay, something is missing, so I should go and do that. That's
Yes.
something which is going to help. So associated with those things, and definitely it's a good habit. Donating blood rejuvenates you. You will feel
Yes.
not only rejuvenated because the blood is getting rejuvenated inside the body, but it's a philanthropic kind of feeling that you get. In fact, we
Hmm.
used to call our couch Sachai ka couch, because if the person is lying down on the couch and donating blood, at that time you ask him any question and he'll tell truth about himself. Many a
Hmm.
times he had such experiences. So that kind of feeling is there in the person at the time of donation. You feel good, and that
Hmm.
really helps. So
Okay.
that's the what I would like to promote, the voluntary blood donation.
So I think that even gave the answer to my last question, where I was going to ask you that what is your one of your memorable experience in the industry. So I think Sachai Ka Couch is summing up and giving us the
Yes,
answer.
yes,
So thank you so much, fam. Thank you for joining us for today's podcast, and we are hoping to have more such podcasts on relevant topics coming up in the industry.
yes.
Uh, Thank you for sparing out the
Thank you.
time.
Thank you very
Tha-
much, Vasu. It was very nice talking to you, coming out with
Thank
certain
you.
insights.